All right, so let's talk about some lung conditions that can affect pregnancy. What happens when someone with asthma gets pregnant? Asthma is a chronic inflammatory disorder of the airways. The airways of someone with asthma are more sensitive to a lot of different triggers. It tends to be characterized by exacerbations and remission. So someone may be fine and then they have an exacerbation and then they get better. Sometimes it's poorly managed and so they just kind of live in that constant state of triggered airways. So what happens, the airways respond, they start the inflammatory response. The airways become swollen, they increase mucus production, mucus production, and they spasm. That can produce some music. When you're listening, you're going to hear that whistly wheezy sound. Okay. Asthma can be improved by pregnancy, worsened by pregnancy, or unaffected. So we don't really know. If a patient is pregnant and has severe asthma and it's not well controlled, we can have poor fetal growth because of inadequate oxygen, and we can have fetal hypoxia. There is a risk of postpartum hemorrhage. And if prostaglandins are used to treat that postpartum hemorrhage, they can actually trigger an asthma attack. Managing asthma in pregnancy, we want to minimize exacerbation. So hopefully before that person gets pregnant, they're well controlled. We want to make sure that they've got their maintenance medications and they take them. We want them to avoid triggers. The mainstay is usually inhaled corticosteroids. If they're inhaling the corticosteroids, they're less likely to absorb them systemically. They work primarily locally. So that decreases the side effects. In an exacerbation, we've got to get oxygen to this person because, you know, we can't oxygenate a fetus if we can't oxygenate a mom. Also, treat the patient in front of you. So in an asthma attack, albuterol is often given. Will it cause fetal tachycardia? Yes, it will cause fetal tachycardia, but better a fetus with a high heart rate than no oxygen, okay? Steroids are given, aminophylline might be given, beta-adrenergic agonist, all of those things that open up the airways. They also increase the heart rate, and you're going to see those changes on the fetal heart tracing. They need oxygen. If they're in respiratory failure, they need to be intubated, put on a ventilator. Okay. Ideally, we don't get that bad in pregnancy, but sometimes you're going to see that. Breastfeeding is not contraindicated with asthma meds. If they're on theophylline, sometimes the breastfeeding baby will get jittery or have some upset stomach or arrhythmia, but typically asthma meds are safe for breastfeeding. Cystic fibrosis is the other pulmonary disorder I want to talk about. This is an autosomal recessive disorder. Throughout the person's entire body, they produce thick, sticky mucus that can't be moved from where it's supposed to move. It affects a lot of organs, but the effects are most serious on the respiratory tract. Infertility is very common. So sometimes you're less likely to see pregnant people with cystic fibrosis, but I have seen it happen. With mild lung disease, they may be okay in pregnancy. If they are really sick, then they're at risk for poor outcomes. The things that increase that risk, if they have poor nutrition pre-pregnancy. There are nutritional problems in cystic fibrosis because the pancreas gets clogged up with thick, sticky mucus, and so it cannot get the enzymes into the intestine that break down proteins and fats. So they have they don't absorb nutrition well. So if they have really poor pre-pregnancy nutrition, if they have really significant lung disease already before pregnancy, if they have pulmonary hypertension already from that lung damage, if they have liver disease, or if they're diabetic, okay, any of those things increase the risk for poor outcome with cystic fibrosis. The risk, there's an increased risk of maternal and perinatal mortality. There's increased risk of preterm birth, intrauterine growth restriction. The placenta may not be able to perfuse well enough, uteroplacental insufficiency, and there's a risk of right side heart failure. When the lungs are damaged, it's harder to pump blood through them, so we get pulmonary hypertension, so we can have right side heart failure. Management, we want the person to be as healthy as possible and at least at 90% of their ideal weight before pregnancy. They may need tube feedings or TPN to maintain adequate nutrition through pregnancy. They need really close monitoring. The pancreatic enzymes that they have to supplement need to be adjusted frequently in order to make sure they're getting maximum nutrition. They get pulmonary function tests in pregnancy to make sure their lungs are not getting worse. Early detection and treatment of infection is critical because infection is what causes the lung damage. Fetal assessments are going to have NST and BPP. They're going to have growth checks because IUGR is a risk. They're going to have fetal movement counts. Epidural or local anesthesia is preferred for birth, and a vaginal birth is preferred. If they have general anesthesia for a cesarean, they should not get anticholinergics because that makes the mucus even stickier. Breastfeeding is safe if the sodium content of breast milk is normal. One of the things that happens with cystic fibrosis is abnormal sodium excretion. So the breast milk needs to be tested for sodium content. If it's normal, then breastfeeding is safe. We're going to come back and talk about dermatologic disorders.